I want to talk about some terminology because this has been frustrating. And Jim, you can relate to this. Jim and I, go way back. And so back in the 80s, I was so frustrated because I found that in Minnesota, when someone was, let's say, at Hazelden or somewhere, they'd send them back, and they were saying they were sending them back for aftercare. But now what they were thinking, what they were sending them back for, was a comprehensive treatment IOP. But they called it aftercare. And I'm like going, aftercare? The terminology has not been consistent in this industry. The most significant change in terminology was moving from calling substance abuse an acute disorder to a chronic disorder. That has changed the paradigm. And if we can keep that in the forefront, then I think as we're doing an IOP or working with families or whatever, that will really make a significant difference in our expectations and our treatment choices. See, I think people, if they have the expectation that this is an acute disease, then they think it's going to be fixed. If we really push hard with educating them that it's a chronic disease, then what you do is you have to learn how to live with it, like other chronic diseases. So SAMHSA, when they were developing the treatment manual for this for IOPs, they call it IOT, intensive outpatient treatment. Other parts of the country, they say we'll call it an IOP. But what I like about this publication is that it really delineates and goes through the different levels of care, what they constitute, and why you'd move from one to another and how that works. So, and I've been especially frustrated here in Dallas because, I'd say 10 years ago, I began seeing facilities saying they were offering intensive outpatient treatment. And then I would ask them, are y'all licensed? And then they go, well, yeah, the counselors are licensed. They're LPCs, they're LMFWs, they're love social workers. I go, but no, is the facility licensed as a facility that's providing treatment? Well, no, we're all licensed. And I said, I would encourage you to go to the Department of State Health Services website and look at what is what, because if you're doing groups, and if you're doing individuals, which is great, but if you're calling that intensive outpatient treatment, that's misrepresentation, because an intensive outpatient treatment, or IOT, is a structured, almost curriculum, continuum, much like when you go inpatient. When you go inpatient, there's a step-by-step continuum, and it's guided by what the state tells us we have to include in our in the time when they're in treatment with us. So it's just not getting them together and having a group or doing process group or having individuals. It's much more comprehensive and much more detailed. So, watching what the wording is on something's important, and getting clarification. People may be clueless, or they may not understand, or they may not. And just find out. And the best way to find out is say, what services do you offer? A lot of Facebook, you go to a lot of websites, and they'll say a treatment program, and they say it'll be for intensive outpatient treatment, and they'll say we offer we have a family program. So then I'll call, or Deborah will call, and we'll say, now tell me about that. What does that include? Well, if the family needs counseling, we'll have them come in and we'll have a family session. Well, that's not a family program. That's family therapy. That's great. But going back to the SAMHSA handbook, when they talk about, and I'm going to talk about that, that'll be the last thing I'll talk about, is the comprehensive information about our family program. And I really think that actually the family's been the missing link, and it's a piece that's been missing from the very beginning. We don't call the client solutions the client, the family's the client. They have a handbook that is about 250 pages thick, and the client's handbook is 250 pages thick. We have, if one of the family members says, well, my love so-and-so, I don't think went to a meeting this week. And I will say, what meetings did you go to? We keep moving it and shifting it back because we want them to go away with their recovery. We want them to have something that is theirs, not that they're doing something on the coattails of another person. And actually, that's the disease model. The active disease is the addict or alcoholic is drinking out of control, and everybody's placating to that. We cannot do that in treatment, in recovery. If we are placating, if family members, I don't like the term family members, they're clients. We've had family clients in our program, and if they drop out, we've had family members say, well, what about us? You're still here. Family members can come into Solutions to our family program, even if they don't have a client in the program. It's called Bridging the Gap. Or if the person, let's say their client's not ready yet, their loved one's not ready for treatment. Or they can stay in, let's say someone goes to Dove Tree, the client, and the family can participate in our family program. And following treatment, the same thing. So we want, and the studies and the research shows that when the whole family's treated as one entity, then the success rate is just skyrocketing. So let me go back to a couple of more terminology and definition things that really throws everybody off. Also, when we were back considering this acute disease, the length of treatment was acute. I mean, I don't put on our website, I don't say expected length of stay is, I don't say this is an 8-week program. I mean, it'd be like somebody going in and getting cancer or chemotherapy and they say, oh, it's going to be only 8 weeks. We don't know. When we do the intake, we talk about what's the average, whatever, but really that really rests upon that individual and their commitment and their ability to embrace the program. So I think when we are trying to have a treatment model, it's based on acute disease concept versus chronic. Right off the bat, we're gonna fall over the edge. The other things that are interesting is another thing in terms of terminology and definitions is, for the longest time years ago, it was chemical dependency. And then we called it substance abuse, and then we call it addiction. And then we call it substance use disorder. So we're always, and I think this is good. I think this is good because what we're doing is we're learning. We're just constantly learning new things and new ways to frame something and new ways to present something. So the terminology is different, and what's agreed upon as an IOP and an IOT varies across the regions. When we talk about aftercare, I mentioned that a second ago. Some places, the term aftercare applies for, has to do with when someone's coming out of a traditional intensive outpatient program, or let's say someone comes out of a residential and they come back and they're in an aftercare. And normally that oftentimes looks like a 1 time a week, 2-hour group, and then also continuing care is another term. So then we talk about continuing care. Well, that usually is involving aftercare and maybe some clinical services. And then, so there's just a whole hodgepodge. That's why when I'm talking with an inpatient place or residential place or even a therapist, regardless, I'd rather just say what it is than throw out a term, because so we can all be speaking the same thing. One of the things that I think is so crucial is that we really embrace the idea that we're on a continuum. In other words, I don't want people to see Solutions as their treatment. I want them to see we're a part of a continuum. Because if they think we're the end all, beginning and the end, that's not accurate. Many times people will come into an IOP from having been in residential, so it's a step down. Sometimes we have people in our IOP, and by the way, when we do evaluations, one of the first things I say is that, if you find it difficult to embrace and accommodate our guidelines and to achieve recovery, we will likely make a recommendation for maybe a residential program. We tell them that up front. And I say, I want you to know that it does not mean you failed or we failed. What it means is that you gave it your best and we gave it our best. And with our best together, it looks like you need more structure. It looks like maybe you need some more resources. So that if they begin relapsing, they're not going to be filled with a failure complex. They're going to know already that this is a common thing that might occur where people move along that spectrum. So I think what's important too is the differentiation between substance abuse treatment and treatment and mutual 12-step programs. You know, treatment needs to be provided by qualified professionals. They need to do a thorough evaluation. They need to do a treatment plan. They need to evaluate from everything from psychiatric stability to medical stability to family environment, the whole gamut. Develop a treatment plan and then engage them in treatment. You know, a lot of times people will say, and I think we need to educate people on what AA is. I think people sometimes throw around the word AA. They got treatment through AA. You don't get treatment through AA. You know. So what constitutes an IOT, according to what SAMHSA says? It's 9 hours of treatment per week, minimum at least, and that sessions are like 3 hours long. Now, when we started back in '95, the reason also I started Solutions is I got tired of sending people out of state because the family had the expectation that somebody else was going to fix their loved one, and they were just going to hang out in Dallas, and when they come back home, everything will be fine. And I'm convinced that the more we can treat the whole system, the better. So I went to Austin. At that point, I did not know a single IOP. I don't know anybody that was offering IOP. So I didn't have anything to model this after, other than when I went down to Austin and I went through a course where they did a course on how to open up an IOP. I also had been in treatment at the Meadows for, back in those days, we called it codependency. Today it's called trauma and everything else. And my husband had been at Sierra Tucson for codependency. So I've been the patient in a facility that I believe had a supreme model of treatment. And then I've been a family member in a program of that model. So when I opened up Solutions, my belief and my commitment was I jokingly say it's an outpatient program. I'm sorry, it's inpatient treatment on an outpatient basis. Well, that's not possible. I mean, cannot be done. You know, it's impossible. But that's how high I set the bar. I wanted to make sure that what we did, we were striving towards that quality of treatment, because outpatient treatment just shouldn't be a drop in the bucket. We have our family members come 4.5 hours a week. That's family. They're in group 4.5 hours a week. And our clients are there 12 hours a week. We have a family weekend that's based on the same structure and model that the Meadows and Sierra Tucson has, where they do the list work, they do the forgiveness and reconciliation work, and all of that. And it's powerful. And it can be done on an outpatient basis. Now, in terms of what constitutes IOT, SAMHSA tells you what the minimum requirements. They don't tell you, they say the minimum requirements is 9 hours of treatment per week and 3 hours sessions. And then the Texas Department also has criteria. Well, what is partial hospitalization programs? Because now we're seeing those arise. Those are defined as 6 hours a day, let me see how many days a week. And actually, like 6 hours a day, and several days a week. So you can see that the intensity, the duration is different, the intensity is different. In a partial hospitalization program, many times they're going to have access to more medical care, more psychiatric care, a lot of those things. And some of them are associated with hospitals, are now freestanding. But again, I think we have got to have a high standard that, let's say if our IOP, if I decided to broaden it to be a partial hospitalization program, that doesn't mean just increasing my hours. I mean, that's that's misleading, to say now that I'm doing more hours and now it's partial hospitalization. No, it's more services too. I've got to incorporate and go to the next level. One of the things I love about IOP, or I keep saying IOP, but is that I feel like it's like a conduit. We get a lot of our referrals from psychiatrists and psychologists in Dallas. So we get people in there. And I want to tell you, when we do evaluations, I'm going to say 8 out of 10 times, we refer them somewhere else. And if your staff isn't comfortable doing that, and because they don't think the person who owns the program is comfortable with it, go somewhere else. We have got to make referrals based on what the client needs, not what the facility needs. So we'll do an evaluation, and then if they're appropriate for our program and other criteria seems to fit, they'll be in our program. Sometimes we send them back to the person who referred them to us and said, it doesn't look like they're really in need of a program as comprehensive as ours right now. And the patient goes, whew, I'm fine. But we'd say, get them into AA and up their individuals. I want people to try at the lowest level of structure, lowest level of restriction, so to speak, and move up the ladder. If you go to the highest level of care, and sometimes that's going to be needed, and I'll talk about that, then if that's not sufficient, where do you go from there? So you kind of want to move along the continuum. We have people in our program who come out of residential, they're in our IOP, and lo and behold, they're struggling. And it's just clear that they left too soon, or they've got some underlying issues, they need more residential settings to deal with some of this trauma, and we refer them back. Again, it is crucial that the client knows this has nothing to do with them failing. They didn't fail. What it means, and actually we need to let them know, because your life and your journey's been so compromised, and the struggle's been so great. It's a miracle. You have used every possible means to get to where you are. What we're learning is you need more than what solutions can give you right now. So again, that's so important in terms of the continuum of care. Within each level of care, there's a continuum. Like when people start off in solutions, they'll start off, and then back in the old days, actually they came 5 days a week, and Monday through Thursday, they were in our program from 4 to 9. They took a dinner break, and then they came back, and they were there from 7 to 9, 4 to 6, and 7 to 9. And on Fridays, they were there from 4 to 6. That was awesome. But due to a lot of reasons, we had to, kind of whittle that down. But our program initially starts off 3 days a week, 3 hours a night. And that's 9 hours. And then individual therapy and family therapy, and the family members come on 2 nights a week. And so then after they've established, we like to look at a 30-day sobriety. We like to look at they've gotten stabilized. We like to look at they have gotten established in the recovery community. Their family is on board. They're many times are getting back to working again full time. Then we taper them down, which could be called SOP, because it's 2 days a week, or phase 2, or however you want to call it. Then sometimes they're there, and lo and behold, any transition is going to be hard. I don't care where along the continuum, it's just change is hard. So sometimes we find that maybe we bump them back to that phase 1 again for a few days to help them get more stabilized. it's so important for the clinician to, you know, frankly, I tell people it's easier, if you want the easier, softer way, go residential. IOP is hard. I say it's like on the job training. It is the commitment and the effort it takes to work, to be in an IOP, to have your family, to have stressors, the very things you conceptualize when you're in residential, they're in your face when you're intensive outpatient. Also, let me tell you, if you're working in a residential place, you probably, if you're a primary counselor, you're probably not doing a lot of case management. You're probably not doing a lot of administrative things. You're probably not doing the intakes, or I mean, you may be doing some, but you're probably not doing a lot of the contact with the family members. So your job is pretty defined. When you're in an outpatient program, counselors, at least at our place, our counselors literally carry the load. Now we all carry it together, and that's what's so neat. Is it's you know, we're a family up there, and it's a lot, but it's hard. It's not just doing group and doing individuals, and I can't stress that more than anything. Being mindful when you're an IOP counselor. You know, our counselors are 24/7, and that's what I'm reading in the SAMHSA material too. It's not a 9-to-5 job. It's, you know, now what's also important is for the clinicians to be in some kind of recovery. I don't care what it is, but some kind of recovery, and I especially think something that has to do with codependency. Burnout, I think, is a direct result of being in codependent, not being in recovery with the codependency. One of the things I am well aware of is I will give my clients and the families everything. I'll give up my all while I'm there. Then when I leave, what they do with it is theirs. I don't take responsibility for what they do with what I give them. And if they, you know, when people sometimes get a chip at Preston or whatever, and, oh, thank you, solutions, I go, you did the work. We gave it to you, but you took it and did it. I'll be interested to hear from some of y'all too. You know, I'm seeing more and more in the literature about the length of treatment, continuum of the length of treatment. And again, we know the research supports that. Client retention is a really, really interesting on an outpatient basis. If you're inpatient, it's harder to get a ride home and get out of there. People do it. But outpatient, you can just kind of go, I'm not going. Or you can lie and tell your family you're going, not going. So retention is really difficult. We have some pretty strict guidelines. And I like to frame it as if you were inpatient. And I go, if you were inpatient, you wouldn't just one day decide I'm not going to go to group that day. You might, but then there'd be a procedure in place to encourage you to get to group. So retention, on an outpatient basis, you have to be actively involved as a clinician to embrace and bring that person into that environment so they can really bond and get invested and get engaged. I want to talk now about family, and then I'm gonna be quiet and let you guys do some questions. One of the things that we do from the very beginning, there's a lot of pushback, but what happens is when this is your policy, it's not so much pushback. But we ask for family members to be accompanied by a family. We ask clients to be accompanied by a family member. Well, I'm an adult. I don't need somebody to come with me. And I go, if you were wondering if you had COVID or diabetes, you'd want a family member coming. So we keep referring back to the medical model and so that it's not about behavior or anything like that. But as a recovering alcoholic, I know when they come to us, they're full of shame. But if that shame governs the choices they make in treatment, then they have really, it'll cost them a whole lot. So what we do is we tell them we really want a family member here. That we say, a lot of times what'll get them is I'll go, they're doing a lot of things probably that are getting on your nerves. They're probably trying to tell you what to do. They're snooping about your bottles or, nagging with you. Yeah. I go, well, our family program is going to help them get their eyes off of you and get their eyes on themselves. So that's encouraging to them. Now, see, they're afraid that if a family member comes up, they're either going to tell the truth, they're going to spill the beans on what's really going on, or a lot of times family members are struggling with their own addictions or their own depression or their own issues. So, and actually we have, when you look at the attendance in our groups, for every one client, we have usually 2 family members. So our family groups are large. We do multi-family group as well, and that's so powerful when you have full families with other families. So let's define the family for a second. And also, I told y'all that one of the things I've been getting information from is the SAMHSA, Substance Abuse Clinical Issues and Intensive Outpatient Treatment. This is by Deborah J. This is It Takes a Family. I recommend everybody to get this. This is life-changing. She has done phenomenal, groundbreaking work. Robert DuPont wrote the introduction, and it's all based on a model of the family being the client. So what we do is if they've been alienated from their family, then we try to find out, well, let's see what that's about and see if we can get them, at least somehow, if we can get them plugged in. Or let's look at what your family is. That family might be your coworkers. It is rare that we have someone in our program who doesn't have some family system involved. And if they don't, what happens is they feel left when the families are there and their families and they don't have it, they feel there's a hole. So they went from not wanting family involved to now wanting family involved because they see the healing that goes on. So we have the family involved in the intake and the assessment process. We have them involved in individual therapy and multi-family therapy. Let me tell you, this is so crucial. We have got to continue to educate and reinforce to the family members that this is a chronic disease, because they're under the illusion, like everybody else, that their loved one is finally sought help, and now what's going to happen is they're going to get fixed. So if we don't address that, we've done a disservice to them. We've got to broaden the concept of the chronic disease. Also, I said this earlier, but when families involved, the recovery rates go up. Clients are encouraged to enter treatment. What happens too is if there's been a relapse, clients are like, oh my God, I don't want my parents or I don't want my spouse knowing about it. So if we had kept them out of the loop, they could have probably gotten away with that. What happens is we walk them through in a loving, gentle way how to tell their loved one what's happened. We have them do a relapse autopsy, and the shame, the guilt will never get healed unless they bring it out in the open with their family members. And what's interesting is when usually people know something's wrong, it's almost like a relief sometimes when you finally call it what it is and you find out, it's a relapse. I also have family members take a look at their relapse behaviors, because they don't need to be learning what their loved one's relapse behaviors are. They need to be learning what theirs are, and they will actually coincide and match up to theirs. It's important to gather information from family members and to state that this is the program's policy. Now that doesn't mean that we don't have some wiggle room. I'm not, but when we that's where we set the bar, so to speak. One way I do it is sometimes I can hook them into coming to family group by I can hook their codependency. because I can say, you know, they're going to have a better chance at getting sober and staying sober if you'll come to family group. Oh, they'll jump through hoops. Now, I went to treatment for the wrong reason. There's nothing wrong with getting them there for the wrong reason. Now, I do believe entrance into change can come external, but for you to maintain it, has to shift to an internal locus of control. I found something that I wanted, but I went there for an outside purpose. Okay, I'm going to stop about this, and I just can't tell you how much the family thing is so important. It's also fun and it's healing, and we get them going to Al-Anon and Families Anonymous. We work hard at finding resources that are going to match and be suitable for different people. One quick story I'll tell, and then I'll be finished. Back in the early days, we had adolescents and adults. And so, and Takata let us have them together. So anyway, this judge from this area, from the Parks area, came in for an evaluation. He said, I want to come to Solutions. And I said, you know, you fit the criteria. It would be a great fit. But right now we have 5 boys, some St. Mark's boys, some Holland Park boys. They're drug addicts and non-alcoholics. I don't think it's going to be a good fit. Well, I want to come here. I want to come here. I said, well, all right, we'll try it for a week. And but I really want you to know, I think it'd be better. Well, that weekend, he said, oh, I'm not going to ever go to AA. If I go to the freshman AA group, I'm going to see people there that I came before my bench. And I thought, oh, good point. So I said, okay, I'll kind of back off on that for a while, for a week. Well, the weekend came, and these 5 boys were going to go to an NA meeting. And if you all ever been in NA, it's a little different than AA. They invited this man. He went to the NA meeting with these 5 boys. On Monday, he said, oh my God, I loved it. He said, my opinion about the 12 steps and about all this is so different. And then he started going to Preston Group AA. So we never know how the message is going to be received, but we have to be careful not to compromise what we believe is in their best interest. So I'm going to stop, believe it or not, and then I'm going to let Brandon give questions.
All right. Thank you so much. I've got some questions. You brought up burnout with clinicians.
Yeah.
And I noticed burnout with other people in the industry, not just clinicians. And I was wondering if you could talk more about that and things that people in this industry can do to reduce burnout. You had mentioned doing work, codependency work, but what are some other things that those of us in this industry can do?
Well, I think the most important thing is for them to find an Al-Anon meeting or a CODA meeting that they can get active in. Just not go once or twice, but get active, get a sponsor, and start to build a community of people with that. The other thing is finding a good therapist that they can work with. See, the thing about clinicians is we know, it's kind of like addicts too, they know what the right thing to do, they just don't do it. But as clinicians, we know what the right thing is to do. But we need to be, we need to be coached, we need to be guided. And so we need to find people we can trust that will take us down that path.
Wonderful, thank you. And I've worked with some other outpatient programs, and some of them have had to make drastic changes due to COVID.
Oh yeah, yeah.
Others have been able to maintain a social distancing policy and keep everything face to face. Have y'all had to make changes like that, or how has this affected Solutions outpatient?
Well, when it first started, the COVID thing, I remember in February, I immediately signed up for an extensive 15-hour telehealth course and certification. So they lifted the HIPAA lifted the requirement of allowing people to do telehealth, but that wasn't going to last forever. So I went on and got the certification, and then I worked with the staff. Now the thing is, in those early days, I'd get on Facebook or texting with Jim and with Steve, oh, I'm blank. Anyway, a bunch of clinicians that have IOPs, and we began sharing, what are you doing? What are you doing? How are you handling this? How are you handling that? We pretty much, what we did is we stopped providing in-person treatment. We moved to Zoom. It's gone great. For the most part, the area that I've been most frustrated is trying to do a good 2-hour evaluation on Zoom. Because some of that, they take it, doing sassy, or doing this, or doing that. Some of it's kind of, and then staying engaged, so now we're now doing evaluations in person. Now we have all the protocols in place. We have 6 feet, we have masks, we have everything. We're not doing groups in person. A few people are coming up for individual sessions in person, again, 6 feet and everything. But we're letting them make that choice if that's comfortable and feels comfortable for them. But I tell you what, it just takes one person in your community to get it, and then everybody's quarantined for 14 days, which is not the worst part. The worst part is everybody's possibly going to get sick. And I think, too, the attitude of the staff is so important. I'm so tired of this bickering going on Facebook about mask, no mask. Let me tell you what, as a healthcare provider, if your attitude is not positive about wearing a mask, your clients will pick up on it. And we owe it to them. It's called accept. There's a difference between admitting there's a problem and accepting there's a problem. When you accept it, there's a surrender. I don't like doing it, but I've accepted it, so I'm not pushing back. It is what it is. But if a clinician, I want to tell you what, we have got to be a role model for them. So that's what we do. We have started doing aftercare. That's iffy because aftercare tends to get larger, right? And so if they get too larger again, we may have to go back to Zoom. So we have got to monitor this. And it puts a lot of stress on the staff because not only they're having to deal with the clinical issues, they're having to now take care of some things that previously have on their plate. So my heart goes out to this. But again, if we will work on our own codependency and our own sense of well-being, that'll make a difference.
Wonderful. And someone just asked, how long are the IOP sessions lasting online per night?
What's interesting is when I took my training, they said you'll find that people actually like engaging by Zoom and oftentimes will be more engaging remotely. Mm-hmm. And I think that's true in some sense. But what happens is because the brain is being fine-tuned and zeroed in, and there's a sense of having to be present continuously. Like when you're doing a group, I don't know about y'all, but I might look outside the window, or I hear a bird or whatever. So I think it's taxing the clinicians, I know, and the clients. So our groups have not been as long. Okay, we used to do a group would start at 6, and then they'd take a break. Back in the old days when someone would go outside and smoke, or just take a break, 10-minute break or 15, and then they'd come back in for the second part of the group. What they've opted to do is cut out the break part and then do group continually. So it's not a full 3 hours, or it's not a full, but it depends on what's going on in group. Individuals, same thing. I think that sometimes something happens when you're physically with something. There's an energy feedback. I really believe there's molecules in the air that, in fact, if you've ever seen the DVD, I Am, get it. Okay. But there's molecules. So if I'm with someone, my energy hits them, and then their energy hits me. And that keeps me engaged and them engaged. So we got to be good. We got to be gentle with ourselves if it's not looking like it looked when we were in person.
Yes, I've noticed that same lack of connection, lack of energy with online meetings since this has started as well. So, you know, any meetings, work meetings, 12-step meetings, you know, so it's something I've noticed. So.
One thing that's real important, I'd encourage everybody do read up a whole lot on the etiquette and the proper what protocol for being on Zoom. Like Brandon, I feel connected with you because our eyes are connecting, even though you know. But the thing is, and Jim, I feel connected with you because you're looking at me. But you've got some out. So when there, but if people are not visible, if they're too far away, or if they're looking down, they don't see how others are seeing them. So there's a sense of disconnect. And actually, I energize to stay connected with eye to eye. I have more energy now when I connect with y'all.
Mm. Well, are there any more questions? All right. Well, I'll give you the last 8 minutes of the hour back. Lois, thank you again so much for this. And